Okay, so we'll give just about a minute or so for everyone to log on, and then we'll go ahead and get started. Okay, and while everyone is logging on, I just want to let everyone know that I put the survey link in the chat. So if you are interested in obtaining ASHA CEUs, the survey is there in the chat for you to fill out at the conclusion of this webinar. So since we are right at the top of the hour, I'm going to go ahead and just give an introduction. And if you miss any of this, don't worry, I'll go back over it at the end. But thank you all for joining us this evening. My name is Brooke McGivern. I'm the Director of Marketing and Communication here at Tim's Medical. We're really excited for this presentation from Jo, who is an expert in dysphagia. Her presentation this evening is going to be absolutely wonderful. And like I mentioned at the beginning, if you are interested in ASHA CEUs, we do ask that you stay for the entirety of this presentation and you fill out the survey. And that survey does need to be filled out in its entirety as well. And that link is in the chat. It'll be sent out via Zoom after this webinar, about 2 hours after. And this webinar will be recorded and uploaded to the TIMS website within 48 hours. So if you miss anything, don't worry, you can go back and rewatch the replay. And if you have any questions or you would like a certificate of completion, please send us an email at tims-univ@tims.com, and I'll put that in the chat as well. And with that, I'm going to go ahead and hand it over to Jo so that she can get started on her presentation. Jo?
Sure, Brooke, I'm just let everybody know that I'm in a physician's, our CV surgeon's office, because this is the only place that's quiet in a hospital and you won't be able to hear all the overhead pages. So if anybody's interested, that's, what is it called? Dead Point? I should know this. I'm in Utah, but that's the surgeon that I work with that's sitting at the edge of that. This is his office. They always let me use this. So I'm going to share my screen. And we're going to get going. I hope, let me see if I can get this out of the way. There we go. So like Brooke said, my email is on the first slide and you can write it down and always email me if you have questions. One of the things that Tim's University and Brooke and Tim asked was that I kind of give a practical approach of what do we do when we see patients, how do we determine whether they should have a modified or not, modified barium swallow, instrumental valve. Today I'm going to go over modified versus fees. And then what is that communication like to the team that's asked me or the speech pathologist to consult? And then how do you pass that patient off to another therapist and where they're going? So I think I've got a great video for you. I have a Mac and my Mac doesn't read very well with certain videos. And so when I get to the video, I'm going to have to do a little bit of IT stuff. So bear with me. Now I'm just trying to think of, okay, it's letting me do this. Financial disclosures. Clearly I have a full-time job and I also get an honorarium. I'm also an instructor at MedBridge, and I think I have 5 or 6 courses on MedBridge. I've reviewed things or abstracts and articles for peer-reviewed articles in DRS or all of the peer-reviewed articles that we can do. And then I'm a reviewer for specialty certification and swallowing. This is actually my last year in 22 years of doing it, which I'm really glad about. I love it, but I need to pass the torch to some people. These are the learning objectives of what kind of things do we need to learn from a medical history and why do we bring people for instrumental assessment. And then when we see things in radiology, how do we determine fear-based versus evidence-based decision-making, whether someone should be able to continue to possibly aspirate or not? And then what do we do for patients to help them summarize the MBS and then the patients and goals and preferences? And can you see that? Okay, because I know I'm in the bottom,
Yes.
and I don't know how to minimize this. Should I minimize this? There.
We can see all of your slides.
Okay.
And that's all we can
I can't see you guys, but that's okay. There are clinically relevant information in dysphagia that's at the ASHA practice portal, because I used to be part of ASHA's standards of care of clinical competencies and things. I think we should have, there's been experts that have been part of all of the adult and pediatric practice portals. They have a lot of articles and common things that we're supposed to do that's evidence-based so that they're there. I'm not going to show you how to do a bedside swallowing eval, but I am going to tell you what is needed in a bedside swallowing eval, because pretty much everybody here is probably a seasoned clinician, or if you're new, You've done clinical, we call them bedside swallowing valves because I work in acute care. Probably should tell you a little bit about my history. I have over 3 decades of working in every single possible thing a speech pathologist can do in medicine, between home health, acute care. My favorite place and my home away from home is critical care. But I've worked everywhere, but my favorite place to work is acute care. So when I go and do a bedside swallowing evaluation in this facility, what they do for any kind of neuro patient, stroke or post-extubation, a nurse does a screen, and that's what ASHA suggests, that there's a screen first and then an evaluation and then a possible instrumental. So when a nurse does a screener, we're on all these order sets for traumas. I work in a level 2 trauma center at Intermountain Health in St. George in Southern Utah. We're on all these, we're able to fabricate order sets so that it's not just when PTs and OTC patients and they see something wrong, they call speech, and we have rehab order sets. So PT, OT, and speech get to see patients for all low and high velocity traumas, strokes, anybody that fails post-extubation, swallowing screens. We're on all high flow patients. And then, of course, intubated patients we see for, which is a different lecture. We do information for that. And then when they're extubated, and then we also see people that are trached and vented. So when I go and do a bedside swallowing evaluation, these are the things that I want you to keep in mind that we do. First, you go in and you have an eval, and then you figure out, why am I having this evaluation? So the first thing you do is you look at the medical and feeding and swallowing history. You do a patient interview, you do an examination, you communicate what you see, and then you document. And so I'm going to go over just a little bit about a medical chart review. Clearly, you look now we have EMR, so we can do the medical history, surgical history. I love to look at any kind of past imaging if you can get to that. We went from a certain kind of EMR to another, but we were able to get to past imaging. So I look and see if they've had upper GIs, esophagograms, anything that could possibly be related to swallowing, chest x-rays, things like that. In acute care, my modus operandi is to never walk in and see a patient without talking to a nurse first and seeing, is it okay if I see your patient? Oftentimes nurses will call if they get patients and they have trouble with swallowing. They'll say, can you see this patient sooner than later because he's NPO? So I always communicate, and I ask the nurses how patients are doing communicatively, as well as swallowing, what the MD notes are, the dietitians, social work, all of that. And then looking at patients' allergies and preferences. Are they a DNR, DNI? What are their preferences? And I think I have a great case history for you. My colleague said it's a great case for you to look at. So the first step in this is to introduce yourself. You talk to the nurse and ask if it's okay for you to see the patient. Is this a good time? This is about 6 o'clock, a little after 6 o'clock here. Of course, we had a stroke that got TNK. So I was doing an evaluation at 10 after 5, and the nurse is like, I'm glad you're here. He's having some slurred speech. I don't really feel comfortable doing a screen. I got to get some meds in him. So I was able to do the evaluation with that patient. I learned a lot from going to other people's courses. And one of the times that I listened to Dr. Kendria Garan talk, she talked about connecting with the patient. And I think we intuitively will do that. But I think that we need to, when we go in and we talk to the patient, I always ask the patient things like, is it okay? This is what I'm here. Tell them my name is Jo. They always call me Jill. And I said, no, it's Jo, but they call me, whatever they call me, I don't care, right? It's just, and I say, I'm here to see if you can swallow. Here to see if you can drink, if you can eat, but depending on what the diagnosis is of the patient. And I also just say, do you think you have any trouble? Have you ever had trouble swallowing? How about taking pills? And if anybody's worked in this field for a long time, it's like a religion to people to take pills. I wish I have videotaped some of the weird things that I've seen for patients taking medications. So I'll say things like, how do you take your medicine? And then the whole time I'm in that room with that patient, if they have a family member, friend, or whatever, I'm also evaluating that patient that's standing with that patient and with that patient, because that's the person that really cares a lot about that patient. And I'll ask them, and the patient will say, no, I don't have any trouble swallowing. Oftentimes I'll ask them things such as, do you cough? Do you take your meds with water? I've had patients tell me they take their meds with bread, they take their meds with a banana. And then I ask permission. Dr. Kendra Garan said that one time, and I thought, I don't think I've ever asked a patient, is it okay if I evaluate you? And so I started doing that. And I said, is it okay if I, evaluate you and see how you do? And I think patients like that connection and that a little bit of control of, yeah, you can evaluate me, or no, I don't want to do this right now, because they are having so many tests flying at them and so many people and coming in and out. that you've got to give them a little bit of control. So when it comes to cognitive and linguistic, why do we test someone if they can follow commands, and what does that provide for us? But there is research that shows that patients that can't follow commands and aren't able to follow commands and are not oriented or distractible have a higher propensity for possible risk of aspiration or not being able to eat enough. You have people work with level 4, level 5 brain injuries, and if they can't attend long enough, then they're not going to be able to take in enough. So it's always good to know if the patient knows where they are, why they're there, what's happening. So the gentleman that I just saw a half an hour, 45 minutes ago is pretty expressive aphasic and apraxic. He could read, so I got one avenue of being able to get in there. But he couldn't tell me that he was thirsty. And I said, are you thirsty? And I just went like this. And he finally went like this. And I said, that's what we need to do. He's yelled scotch. I want a scotch. And I thought, well, you're in Utah. I don't have scotch with me at my desk. But anyway, you look and find out, from the patient where they're at. And there's odds are that of liquid and purity aspiration are significantly higher for people that can follow multiple commands. And why do we do this? Why do we look at someone's physiology? And we look at their physiology, their structural integrity, and their differential diagnosis. So the whole time I was in the room with this patient, I'm looking at their symmetry of their face. I'm looking at their ability to scan right, left. And I look at their overall condition of their salivary flow. This guy was very dry. He came in at 1 o'clock. I saw him at 5, just because he finally just got up to the ICU at about 4:30. And I just look at overall what's going on with that patient. Do they have a right facial droop, left facial droop? I also listen to patients' lungs and I do a cough. So generally in a bedside swallow eval, you do a cranial nerve exam, and you look at everything. You look at motor and sensory. I'm not going to go through that, but this is from Dr. Kendria Garan. You're looking at symmetry of patients, the strength. I always like to have my patients, when I get into trial feedings, I'll tell you that I like to have my patients feed themselves. Sometimes when I first start, I'll start with ice chips, and maybe if they can't feed themselves, I'll make it a little messy on their face, on their affected side, just to see if they have sensation, because sometimes if they can't follow the commands, they can't tell you whether they can feel light touch or not. But these are the things that you look at in a cranial nerve exam. And I usually I'm a little bit linear. I like to start with ice chips first and see if they can chew, if they initiate a swallow, and how they do with that. Then I go to liquids, which is generally water. And I will do pureed. And in our institution, they have various types of yogurts, flavors for yogurts. I try and give as much protein as I can versus applesauce and crackers. Solid foods, we have 4 different types of cheeses, if you can believe that, if they're not lactose intolerant. So I'll see if they can chew the cheese. And then I just asked this Riley, the nurse, I said, do you have meds to give this patient? She said, yeah, I have to give him an aspirin. So if the nurse has to give meds, then I try and see how that patient takes meds. After you do an evaluation, who are you going to communicate with? So the very first person I contacted, the nurse was in the room, as I said, this is what I'm going to do. I'll call the doctor. And these days you text a doctor and said, saw your patient in 266. Looks like he's good to go. He's a diabetic. I'll put him on consistent carb. This gentleman had a little bit of trouble taking his meds, so we're going to bury his meds in the pureed food, let him swallow that, and then let him drink water to flush it down to make sure things get through the esophagus. And I really think that the patient's the main part of this, but these are the people that you communicate with when you're doing any kind of a speech and swallowing or cognitive eval when you're working with a patient. What can we see in the oral phase? You look at bilabial seal. This gentleman had a little bit of a right facial weakness, and so he was a little bit messy on the right and didn't feel it. I can tell whether he's masticating, if he's pocketing on the right or not, if he has any sensation intraorally or not, and just the bolus control. What can we see in the pharyngeal phase? I used to, a long time ago, I can remember lecturing 100 years ago and telling people you got to put 4 fingers here and you'd be able to assess whether they have good laryngeal elevation. And you can tell that there's no empirical evidence to they have some, but you can't tell if it's adequate and if it's safe. You can't tell airway protection, initiation of swallow, or clearly UES opening. But we do nowadays have a tremendous amount of people that are doing research about predictors of aspiration. One of the things that I hear a lot about is wet vocal quality. There's a lot of people that have done research with wet vocal quality. It's not really reliably perceived as wet vocal quality. Also, there's a lot of other things that can make someone sound like they have a wet vocal quality, such as fluid overload, if someone's in congestive heart failure. So it's not always reliable to say, well, they've got a wet vocal quality, so they must be aspirating. So that's not always the most reliable, but reduced pitch elevation, Melandraki and those guys, is more predictor of a higher Pen-App scale, because the ability to increase and decrease in pitch is that same reflex that does the swallow reflex off the vagus nerve. Dysarthria is another one that might be a risk of aspiration with stroke patients, and then cough strength. Clearly, if you don't have a strong cough, then that might be a risk of aspiration. So those are the things that you think in your head about what does silent aspiration mean and what are the largest predictors. So the biggest one that we did that we loved when it came out from Dr. Susan Langmore was the predictors of aspiration pneumonia and how important is dysphagia. And if you think about it, if this sentinel paper, the dependence for feeding was the biggest thing for a risk of aspiration pneumonia, dependence of oral care, decayed teeth, tube feedings, generally because when their tube feedings are NPO and people don't get ice chips or whatever to be able to continue to get that swallowing, reduced activity level. But if you look on all of these, swallowing is not the top predictor. So like Jim Coyle and I lectured one time together recently, and it was the key is not always just to have no aspiration. I mean, can't always be your end goal, but reduced aspiration always good. Current smoking, esophageal dysmotility, we see a lot of people with that. I'll talk a little bit about that. Pharyngeal delay and excess residue and xerostomia. So remember, though, for an aspiration pneumonia, it really refers to an infection that's caused by less virulent, but you have to really have 3 requirements. You have to have a compromise in the airway protective reflexes. You have to have aspirated material, which is more harmful to the lower aspirates. So you have trace aspiration that's got to get all the way down the trachea into the bronchial areas and then into that. So you also have to have a susceptible host. There's not just aspiration that can cause problems. You have to have 3 susceptible requirements that will cause the patient to have an aspiration pneumonia. So critical thinking, sometimes I've had physicians say, well, they don't have a gag reflex, so that means they have a swallowing problem. But I've seen plenty of people that have absolutely normal gag reflexes or hypergag reflexes, and they have trouble swallowing. A PEG tube prevents aspiration pneumonia, which we all know doesn't really happen because you can have reflux aspiration from that. If people aspirate, give them pureed diet and nectar liquids. And we know that this case study that I'm going to show you is not always the best thing for patients. But use straws, no straws. I like to let patients drink from a cup and a straw, see if it's different. We have those big plastic cups with those big, huge straws. I always take those out and throw them away, not because I don't like straws or I think that's going to have a problem with somebody drinking. It's the fact that they leave that in a cup, a plastic cup, for the entire duration of that patient's hospital visit. And that's gross to me. So I'd rather just have a straw in there so we can change it and have less infection and less just bacteria in someone's mouth, that you put something in someone's mouth day after day. Also, if I have a patient like the guy that did today, he did really well, so I put him on a consistent carb diet. But if they don't do well, the worst possible thing is NPO and not letting them have something to swallow, because if you don't use it, you lose it. So oftentimes in the acute care, we like to do things called sips and chips, where you can have ice chips and sips, maybe give meds orally with pureed food, because oftentimes nurses would prefer to have something given orally versus IV. And so those are the kinds of things that you have to think about. Like, okay, so do I take this person for an instrumental eval, a modified barium swallow or not? Should we wait a day? Let's see what he's like 24 hours. So remember, I'm thinking acute care, not outpatient or someone who's had an established dysphagia. So these are your first time seeing them. These are the things that you need to go through. Do we do an instrumental? We do a modified or fees. Generally, if I think that there's going to be an esophageal component, I'll do a modified barium swallow. If I think it's just laryngeal and oral, I'll do fees. And then I look and I document. So I went back to the office and I documented why I called in, looked at the cranial nerves. I document the motor and sensory for cranial nerves on this patient, what he did with trial feedings, if he could do sequential swallows or not, what my impressions are, my recommendations. And then I communicated with the physician and the nurse. And I'll communicate with the dietitian and also the family. Now, The daughter on this one was always like, this is his preference of what he likes to drink. This is what his preference is that he doesn't like. He does not like cold water, things like that. So I always like to watch family members and say, tell me a little bit about what they like and dislike so that we know that and we write that on that communication board. And what are the goals of the care for that patient? And that a lot of times I have patients who are DNR, DNI, and they're like, I don't want to feeding tube. So I'll document that. Patients refusing feeding tube at this time, we're going to do the least restrictive diet and beef things up. And so that's the case that I'm going to show in a little bit. I'm going to review a little bit of healthy swallowing. So we do have normal swallowing. For older people, I'm going to talk a little bit about more older people, but we do have swallowing that have variability. So when you look at someone swallowing, it transports things from the oral cavity to the stomach. It needs to be relatively safe and relatively efficient. It happens 500 to 700 times a day. So there's times when I can get someone to eat, snacks, but I can't get them to eat 3 meals a day throughout the day safe because they fatigue or they peter out at the end of the day or they have more atrophy. So the thing is swallowing muscles can atrophy within 48 hours. So NPO, what's the least that you can possibly do for that patient to satisfy that patient and that nurse? So we like to put patients on sips and chips and just have ice chips. So at least they can have something to swallow. Variability factors are age, sex, and all that, which I'm going to talk about as we get older. So this is a picture on the left of my mom when she was 85 and my godmother who was 100 in this picture. My mother did not dye her hair at the time, so they don't get gray until they're older. My Aunt Pauline was vain and dyed her hair. They're both terribly deaf. They both had hearing problems and wore hearing aids as I do. But I want you to look at the fact that they are 85 and 100. They look great, but they do look, they're older. And we're going to talk a little bit about older swallows. There's a lot of swallow to swallow variability. There's a little bit of residue. Laryngeal closure duration actually increases, which is nice because when you swallow and you're a little bit slower than those vocal cords and the false and true vocal cords will close and protect the airway, but people do penetrate. They penetrate with liquids. Oops, sorry. These are the kinds of things that are normal. So we do have diminished oral pharyngeal sensation when we get older, as we get older, especially old, which is 80 and I think to 100 now. But penetration of thin liquids is normal after the age of 50 and before the age of 50. So sometimes it used to be after, but Jim Coyle and I talked about it, and it can be before 50. We did our research for our fees, and three people aspirated that were in their 20s when we did our research of normal people. Some residue is normal and decreased lingual and pharyngeal muscle strength, especially within 48 hours of a feeding tube place, which can be decreased. Dr. Kendria Garan talks a lot about laterality. So this is what we see in an AP view. Sometimes today I did a modified barium swallow on an inpatient. He had right laterality. Sometimes you can have left-sided laterality, and that's normal. When we get older, we have a little bit of loss in height. Unfortunately, we increase in body fat, decreased hearing and sense, and our oral cavity has decreased salivary function, loss of teeth and gum tissue, things like that. Your mobility and thickness and your the ability to understand what's in your mouth, the sensation of what you have in your mouth is decreased. I think a lot of it also has to do with meds. When people have to go on meds, it can decrease their sensation. Their salivary function. You also have slower alimentary tract. So especially people that are diabetics, and the older that people get the diabetics, the more brittle the diabetics, the longer they have. I find that they have slower esophageal phases, slower gastric emptying, lots of constipation, things like that. Aged nervous system, our potential, our speed, our motor responses, our balance is a little bit off as we get older, and we have a decreased functional reserve capacity. So as we get older, those are all normal. So if we see that, we think, is this from the being in a hospital for 3 days? Is this from the stroke, or is this just normal aging? And once again, these are the kinds of things I'm just review of what can happen when we get older. They get early satiety. They don't want to. I had a patient yesterday who I saw, and he goes, my wife doesn't think I like her food because I don't eat it. I don't eat very much. And I thought, I'll guarantee he has an esophageal problem. And he did. It took 3 minutes for a bolus to get through his LES. So it affects our respiratory system. We have a decreased cough, diminished ciliary clearing, longer respiratory cessation during swallows, everything kind of slows down a little bit as we get older. 40% of healthy community dwelling seniors will experience dysphagia. It advances when you're in with comorbidities. It also advances a lot more in long-term care. So remember, do healthy people penetrate and aspirate? Yes, healthy people do penetrate. And some patients do aspirate, but it really depends. And Dr. Grand has a great course about that. If they frequently do it, and especially if it's after this swallow, generally during the swallow is more normal than after the swallow. And if they aspirate or penetrate with more viscous material is when it's more deleterious. So these are the people that we see for modified barium swallows from birth to senescence, as you know, but you needed to use a standardized measure, right? So we need to use CMS guidelines. We need to be able to do things that are consistent across the country. So if Brooke does a modified barium swallow in Iowa or Ohio or in New York, then the patient will do the same thing in Utah. And CMS and Medicare in 2020 said we need to standardize them. No more doing things crazy. No more bringing food into a radiology suite and testing them with that. You need to test patients with the proper examination at the proper time. So this MIPS is measured in 4 ways for quality improvement, promoting interoperability, and where you replicate it, and it advances the care information. And what they like to know, the key measure is if we do a modified barium swallow on a patient, we need to communicate with the care coordinator of who referred that and who gets that patient. If we don't document that, Medicare is going to start coming down very, very hard on us. And these are the kinds of things that you look at when you're doing the purpose of a modified barium swallow. You're going to look at the severity of what's happening. Is it mild, moderate to severe? You're going to look at motor and sensory communication, and the evidence, not opinion, should always guide our decision-making process. So the purpose of the exam is not always to assess whether people are aspirating, but to look at the physiology and the functionality of that patient's ability to swallow from mouth to gut. So I usually will tell the radiologist when I'm in there why I'm taking the patient down, and I'm focusing on physiology and not the bolus. We use Veribar. It's a product that does not coat the mucosal lining. And that's the product that we should use in radiology. They're asking people to water down barium. And I think, but that barium coats the mucosal lining and it's not appropriate. And then people in radiology will say, well, this stuff that you're wanting to use is expensive. And I thought, well, everything in radiology is expensive. You would never ask them to water down a nuke med procedure, or if someone had a CT, you would never water down something in their IV. So why are you asking speech pathologists to do that? We're going to make sure that when we do a modified barium swallow, I'm just training a new clinician, not new, but she's a relatively new clinician. And she'll give like 1 teaspoon of pureed food. And I said, you got to do a sufficient amount of swallows to really look at that. If there's any variability, pattern to pattern swallowing from mouth to gut, all of that. But you need to make sure that we do this in less than 3 minutes. I like to do it in less than 2. We need to look at it at 30 pulses per second, record it at 30 frames per second. We store it in PACS and Visage. It's absolutely imperative that you review it because at real time, it's very difficult. And then document. These are the things that happened in the last 40 years. We now have a lot of objective measures when we do modified barium swallows at our institution. We like to use the digest because it gives you a safety and an efficiency score, but there's objective measures that you can use now. And luckily we have a TIM system. And so we are able to score things and give us a safety score and an efficiency score with the patients. And next year I hear that the rest is going to come out, and I'll talk a little bit about that. What decisions do we make? I saw a patient today who aspirated. And so at that point is when you try and do a compensatory strategy and minimize the aspiration, and if they consistently do that. And then the decision of whether they should eat or not eat, should be between the physician, the patient, and the speech pathologist. The key is to communicate it. If we don't communicate this in the EMR CMS standards, Medicare is going to come down hard. They're going to come down like a ton of bricks on us, because if we don't say, Dr. So-and-so, like Dr. Wallen referred for a modified barium swallow secondary so-and-so. And then if I don't put in my report that I communicated with Dr. Wallen and the nurse that's taking care of the patient, notified them of the results, they agree with the recommendations, that's going to be a big ding for us. So in our institution, we see all of the outpatient modified barium swallows that come from our skilled nursing facilities and the people that walk in. Our acute care team does that versus inpatient or outpatient. And so anytime I have a speech pathologist or a physician that refers to me, if it's a speech pathologist and a physician, clearly it's got to be a physician, but if the speech pathologist initiated it to the physician, I will always say for my recommendations is to return to that speech pathologist per their plan of care, because it's not my job to do a plan of care for a patient, but my job is to document the physiology of what I saw, the safety and efficiency score, so that speech pathologist can get a visual idea of what happened in that radiology suite and make the best decision on what to do for the patient. So let me stop right there before I do a case study on Robert, because I see a hand up, and I don't know if I should answer that or not, Brooke. It's up to you.
Yeah, there are two questions, and I think they'll be pretty fast for you. The first
I'm
is,
sorry that was really fast, but I kind of wanted, I think when I talk about this case study, you guys are going to be like, wait, yeah, but. And I'm going to say, okay. So go ahead.
no, it was wonderful. This first question is, can you repeat what was the normal timing of penetration before, during, and after, and what is the normal response?
Well, and you know what, if you want, I can definitely email me and I can give you that, because I've got some great information from Dr. Garan that has a table. And Brooke, if you want me to send you that in a PDF so everybody can have it, she has,
That'd be
and
wonderful.
I've asked her and she said, go for it. And she put together a perfect amount of slides for what's normal penetration, normal, aspiration, PENAP scores with liquids, and then what happens with residue. Do people have residue, and is this normal, and what age range? And so I can put that in a PDF for you and send that to you, because that was I think that what was interesting about that is, first of all, I love the fact that someone put that all together for all of us, because I don't have the time to do that because I'm seeing patients all day. So I love the fact that people that are in academia and clinical work will do that for us. Secondly, I've talked to a number of people that teach fees, and a lot of people, will do entire courses for fees. And what do? They bring in normal people so that you can practice on a normal person to how to pass a scope. And so I've been practiced on numerous times in my career. And what's interesting is if I call someone and say, hey, Lisa, she does a lot of Bluefield in San Diego. Do you ever have normal people walk in and they aspirate? And she said, yeah. And I really wish the world of fees that teach people to do that would do some kind of database about, we're seeing normal people aspirating on fees, because that kind of freaks us out in radiology. And we think, gee, what should we do? Is this normal? So I would love to have people out there that train and do fees workshops to do a database together across the country. Just something that's like off the top of my head would be great to have for us. So yes, penetration is normal during the swallow. I think the PENAP is to a 3. When it gets to be a PENAP of floor to the level of the vocal cords, and is slightly ejected, is a little bit less rare, but a PENAP of a 1 and 2 is normal, and especially over 50 years of age. Now, the thing that is concerning to patients, if this is answering your question, Brooke, is the frequency. So if I had a patient the other day where the frequency, and this is what I love about the digest, is I thought, that it's not too bad. He doesn't have any pulmonary problems. But he frequently, and I'm talking about more than 50% of the time, he frequently penetrated. Now he's 80 years old, but he penetrated probably more than 50% of the swallows. And we give a lot, like I'll give 180 ml or 200 ml, depending on what I need to see in the esophagus. And this gentleman had a really significant dysmotility in his esophagus. And so when I scored it, he had a score of a 1 for safety because he penetrated frequently. Now, if it just was infrequent and rare, then he would have had a safety score of a 0. So if nobody has access to those articles, Brooke, I can send that PDF to you that Kay Hutchinson did. And that's a fantastic way to look at something and give you a more of objective, satisfying way, whether this person's safe and efficient or not. Any other question before I start with Robert?
The other part of that question was, what would be the normal response to penetration? I'm assuming the attendee is probably asking that because often online I'll see people discussing documentation of silent penetration. So they wanted to know what the normal response to a penetration is.
Well, it's generally silent. People will penetrate. That doesn't mean that they always will throat clear or cough. Oftentimes they'll take a secondary swallow, but penetration, I don't know. I don't even, what I'm more concerned about is if after someone swallows and there's like 10% residual fluid or food in the pharynx and they don't do a spontaneous swallow next, that concerns me because then their sensation is more decreased. But if you penetrate, and like I said, we do normals a lot and they penetrate, and normal 30-year-olds don't clear their throat. They penetrate and they're silent. So are you saying that a silent penetration is more risky than a what, a cough or a, I don't know,
The
I'm not on Facebook or anything like that, so I don't know
That's
the,
okay. There's a
okay,
lot of discussion about what the on social media about what the normal response to penetration is, but there are quite a few questions now, so I think we should probably move into the case
okay,
study and then answer them at the end.
okay. All right, and
Cool.
like I said, I just did that lecture with Jim Coyle, and he's the one that did Dr. Coyle, and he did the PENAP score, and we talked about penetration. He has a lot more gravitas to talk about the bias about that than I do. Does that make sense? I mean,
Yes.
he's like, so what? So they penetrate. And if you talk to a pulmonologist, and then I'll get to the Robert, this case study. If you talk to a pulmonologist, they'll kind of laugh at you. They'll say, really, so what? I mean, so they penetrate. So it has to go below the cords, below the cricoid, into the trachea, into the right or left main. I mean, there's not that, like, we penetrate, normal people penetrate. We penetrate and we're fine because we're ambulatory and we move and we brush our own teeth. Remember Susan Langmore's, we get up and we move and we feed ourselves. So penetration and aspiration for those of us that are over 50 aren't going to kill us because we don't have those compromised immune systems and we're not immobile and we're not swallowing. So this is what I'm going to talk about. This is a great case study because I'm sure it's going to freak a lot of people out because this guy's not easy and had significant preferences. So Robert is DNR, DNI. He comes into the hospital and the hospitals, he came in actually to our ortho floor. He was admitted because he had AMS, which if you don't know, that means altered mental status for over a week. He was weak, he was febrile, so he had a fever. He had issues with his Foley catheter. He had an indwelling catheter because he had a very large prostate. He's waiting to have some prostate surgery. He's 85 years old with Parkinson's, has a history of dysphagia, BPH, and osteoporosis. And so how do we know that he has a history of dysphagia? Is he had a modified barium swallow at our institution about a month before that and aspirated on thin liquids, nectar, and pooled with pureed food and had no sensation with that. So he was recently hospitalized for 7 days for COVID. And was discharged to a skilled nursing facility for 2 weeks. When he had COVID and he was really sick and he was very, very weak, is when they did the modified barium swallow. And my colleague Belinda did it. He was discharged to a skilled nursing facility for 2 weeks, and then he went home for 2 days before he returned to the hospital. Remember, he's got altered mental status, febrile, all of that. And I look at this history and I'm thinking, okay, this is like a typical 85, lots of comorbidities, kind of a mess kind of guy. CBC is normal, urine culture is positive. So he's got an indwelling catheter. That's where he's getting his altered mental status, is his UTI. Still testing positive for COVID, which is kind of ridiculous because it's been like almost 3 weeks. Chest x-ray was completely normal, completely normal. His physical exam from the doctor, he's alert, he's oriented, his vitals were normal, he's cooperative, very delayed response time, weak bilateral upper extremities and lower extremities. And the assessment in the plan was to kind of figure out what's going on with this UTI, which was causing his metabolic encephalopathy. He was weak, he had dysphagia, see the MBS in the hospital when he had COVID, which I looked and I reviewed, totally trust my colleagues. He aspirated on thins, pooling with more viscous material, and he had a slow esophagus. He's DNR and DNI. So I go in and see this evaluation, and the physical and occupational therapist went in right before me because I was walking into the room and they said, is it okay if we get him up in a chair? And I said, absolutely. I'd rather see a patient in a chair than a bed. And so they walked in, they had gowned up and masked and everything. And I was just, still looking at his chart. And I walked in afterwards. And the patient just looked at me and his eyes lit up because I was the only one in the room that wasn't masked. Because I mean, the guy had COVID 3 weeks ago. I think I'm perfectly fine. You can disagree with me, but I believe that patients need to see my face. Anyway, the OT looked at me and she goes, "He's a man of few words." And I didn't quite catch her cliche about that. Just thinking, okay, whatever. But his response time, motor response time, and verbal response time was extremely delayed. He was a one-person max assist transfer, very minimal communication with the PT and OT. And I just was watching how they got him up, how they moved him, if he was following commands. That's that whole linguistic cognitive aspect, right? Very flat, very typical Parkinson's. And their goal was a one-person min assist transfer so he could get home eventually with his wife again, independent in feeding and independent oral care. So in our institution, if anybody has a risk of aspiration, our OTs immediately get that person trying to independently do oral cares and feeding because they know that that minimizes the risk of aspiration pneumonia. So I went in and saw this gentleman. I'm going to call him Robert. He was severely delayed in his response. It's like 20 seconds. I would ask him a question and I would say, he has a last name that sounds either Spanish or Italian. And I looked at him and I said, "Are you Italian or are you Spanish?" And he would stare at me. And I'm just waiting because I'm thinking, are you having a comprehension problem? Are you hard of hearing? And he would respond in a very flat monotone. He said, "Italian." And I said, "Oh," and I said, "My mom is Sicilian." So he goes, "You're not Italian then." And made fun of me and started laughing. And he finally had a facial expression, but he was really hard of hearing. He could follow two-step commands, became a little bit more confused with three-step. He was alert, he was oriented, and I was sitting with him. I asked him, if it's okay if I gave him something to drink. 20 seconds later, he said, "I don't like ice." And I'm like, okay. And then he looked at me 20 seconds later and he goes, "No thickened liquids." Got it? And I went, okay, great. And so here I am thinking, this is a guy who had COVID, was aspirating, got Parkinson's. We all know if you looked at Protocol 201, what's kind of the risk of Parkinson patients with thin liquids and the whole Jerry Logeman thing, which I can go over if you want me to later. And I'm like, okay, so he's a risk of aspiration. He's aspirated in the past. He's telling me no thickened liquids. That's pretty, with an altered mental status, that was pretty emphatic, right? So I do my bedside swallow. It's got a little bit of left labial droop, little bit of drooling. He had mildly decreased coordination lingually, but he had really pretty good strength. His dentition was great. He had a gag. He was strong. His vocal quality was decreased for prosody, of course, because he's Parkinson's. And when I assessed his lungs, he had great inspiratory and expiratory pressures. He was doing great. He could cough really well. And I listened to his lungs and his lungs were really clear, right? And then I called his wife because his wife was on the board and I said I was going to do this, who I was, and that I was going to do this bedside swallow eval. And she goes, "Well, I'm going to tell you right now, call me when you're done. But I'm telling you right now, we don't want thickened liquids." And I thought, somebody has seriously put this guy on thickened liquids. And that's been a problem for them. I said, "I'll do whatever you want to do. We're going to do whatever you and the doctor want to do. But I'll honor those wishes. Let me see how he does." So because she couldn't come in. So I did trial feedings. I gave him some ice and he chewed them, swallowed them. And then he said to me, "I told you I don't like ice." And I said, "Well, I just want to see if you can chew, and I'm sorry." And he said, "Don't give me another ice chip." And I said, "I won't." Now, remember, this is a very delayed response. With liquids, he could do single and sequential swallows, but he had inconsistent coughing on sequential swallows. Did pretty good with the yogurt. He fed himself, swallowed immediately. I didn't really see any distress. Nothing was really falling out of his mouth. He didn't have a lot of anterior loss. He had distress. He couldn't pass a 90 ml water challenge. So we do have patients kind of do a Yale swallow protocol where we do 90 ml with them. And then the nurse walked in and said, listen, I really need to give his levodopa, carbidopa. And I said, okay, let's try it. We put it in, I asked the patient if it's okay if we put it in his pureed food and then follow it with liquids. Because remember, he's got a history of some esophageal dysmotility. So what I did next was the patient preference was, as he said, he doesn't want thickened liquids and he doesn't want cold drinks and he doesn't want a blended diet. Like, don't put me on things that it looks like it came out of a baby jar. And I said, okay. So we have a communication board and I called the wife. She was adamant about no nectar liquid. She said in his care center, they wouldn't let him have water. They thickened everything and he wouldn't drink it. So I'd sneak him in his coffee every morning. So when I'm hearing someone saying that they're sneaking a patient in coffee, I'm like, okay. And he's got clear lungs. I'm like, okay. So we ordered soft foods. And in our institution, what I did was I would black out things that I didn't think that I would like him to order. And then I put all the precautions on the wall, called the doctor, and the doctor said, he goes, did he do okay? And I said, okay is the key word. Okay was it. Like I think we're going to do what this guy wants. His lungs are good. We ordered EMST for him, expiratory muscle strength training, some respiratory therapy. I said, let's keep his pulmonary system going. OT is going to work on keeping his mouth clean and he's going to try and feed himself. I put him on a soft diet, thin liquids, single sips, float meds for now. And this is the other thing that the wife said, we don't want to modify barium swallow right now. And I said, okay, can you tell me why? I'm happy to, do whatever you want. I said, if he's a DNR, DNI, we'll do what you want. But this is, we can see how he's doing. We can see if he's better. And she said, I think he'll do better, but I don't want to do it right now. And I said, okay, so we didn't do it. So the decision was upright in the chair, soft foods. I blacked out the items that were inappropriate, float the meds, assist with meals just because he was a little bit delayed, aggressive pulmonary tasks. And then he went to a skilled nursing facility. So what do I do? So luckily we are a nice community. We have great speech pathologists in our community. And so he was transferred to a skilled nursing facility 3 days upon admission. I called the people over at Coral Desert and said, you're going to get Robert. These are his and wife's preferences. These are his wishes. These are what we've done. And I had a print off of his little precautions of what to do just from the swallowing eval he did when he was super weak. From radiology. And I said, this is what they would like to do. And they said, okay, we'll follow through. And I called the wife. I called the wife first and told her everything. And then I said, is it okay if I tell the speech pathologist is receiving him what he was doing here? And she goes, please, because I don't want to have to explain to them. She goes, all I said to you is I don't want it. And you got it right away. Because I usually have people who push back and get mad at me. And this is what my husband and I have wanted to do. And if it's meant for him to aspirate and die, then that's what it's going to be. But we don't want this. And I said, okay, fine. That sounds good. So he went to the nursing home and he was there for, I think, 2 weeks. And the speech therapist called me up and she's like, hey, I really think Robert's doing a lot better. The nurse and Robert want, he's not delayed anymore. He's talking, still pretty bad mobily walking, but he's doing really well. Let's do a modified barium swallow. They ordered it. They brought him in, and he came to do this modified barium swallow. And they are like, I'll guarantee he's not going to aspirate because he looks really good at the bedside. Every now and then he's coughing, but he looks great. And I said, okay. Let's do it. So they came and did a modified. And I'm going to escape this a little bit. This is where my technical, sorry, that's my cat. She's very photogenic. So this is Robert. I'm going to stop this. For some reason, because I have a Mac, my initial view doesn't show up, but I'm going to show you a little bit about, okay, let me give a caveat. We have one of those chairs and he couldn't get up onto the chair that was a little bit higher because he came in a wheelchair. And so unfortunately, we didn't do an AP view on him and we did him in the wheelchair and we have this permanent C-arm, on a table. So we just did a lateral view with him because he goes, I'm not comfortable on that chair. And I thought, okay, they're a very particular couple. And I said, okay. And he remembered me because he said, you're the one that's not Italian, you're Sicilian. And I said, yeah, that's true. I get it. So he was laughing. He likes to tease me. I said, do you think you're doing better? And he said, doing my exercises. I'm blowing in those things every day. I'm going to do great. And I said, okay, so here's his initial view. And this is a bolus hold. So clearly he's still aspirating and he's doing multiple swallows. And inconsistently, this gentleman would aspirate silently. Clearly, I asked him to cough. He did not clear his airway. So this is better, and this is much better than when he had COVID. So this is a little bit with a chin tuck. I'm sorry, this is to make sure his esophagus was clearing with the liquids. So I did give him nectar just because I wanted to try nectar and see. He did better with nectar. Pureed, he did a little bit better with a chin tuck, but his face was out of it. This is pureed food. So he does do a secondary swallow and he does penetrate with that and he does pool, but he's not really, right? He's not really feeling it. I had to cue him to do another swallow. This is the pureed food in the esophagus. So we like to follow, we like to follow the bolus from the mouth to the gut, and we'll follow it from the UES to the LES. And if they are demonstrating esophageal dysmotility, we'll stop the flora, we'll look at it for a little bit, we'll stop and we'll wait 60 seconds and we'll see if it has cleared through the LES. So that's why you're seeing like, why is this flashing on and flashing off, is because we don't want to radiate the patient too much. And so we'll flash it on and watch a few seconds after 60 seconds. And if it's still showing that he's got food in his esophagus and he has some motility issues. So he's eating a cookie, channels it into his throat before he swallows. So this doesn't look real great, right? This doesn't look like the best swallow. And then I gave him the cookie and the esophagus were still in his esophagus. I'm sorry, the cookie and the pureed were still in his esophagus 60 to 90 seconds later. He loves carbonated. I spelled it wrong when I was in the system. He loves his Diet Coke, so I gave him some Diet Coke, did better, right? A little bit of penetration, did better with that. And that kind of helped his esophagus clear. And then we gave him a pill with pureed because that's how he was doing it. He still had that typical anterior posterior rocking motion that you see with Parkinson's. And he said he didn't like taking medicine with blended foods. So I gave him, I did that. And then I said, you want to try it with the liquids? And he said, yes, was able to take the pill that goes in through the UES and then went in through the LES. So what I've been seeing lately, which is kind of interesting, is now I'm trying to figure out what happened to my PowerPoint, is how do I do this? Oh, it's because this is in the way. I'm sorry, guys.
I would say, I think if you click play from, oh yeah, there you go. You got
There
it.
we go. So, and his wife has total anxiety. This is what was so funny because she started kind of, and the speech therapist said, you've never really met the wife personally, right? You only met her on the phone. And I said, yeah. And she goes, well, she's interesting because she's got a lot of anxiety. That's why she doesn't show up for things. But when she does, she dry heaves and vomits a lot. I'm like, okay. So she came with them. I said, do you want to be in here when we do this? And she said, oh, no. I'm too anxious and I'll throw up. And I thought, okay. So I handed her a barf bag and said, in case you get anxious out in the waiting room. Came in and I showed the wife and the patient. And she goes, so he's not aspirating anymore. I said, and I was showing her, no, he's still aspirating. Sometimes he coughs and sometimes he doesn't, but he doesn't like clear his airway. And that was, I'm trying to think of if I wrote down his digest, but I believe his digest was a safety of a 2 and an efficiency of his 2. I'll see if I wrote it down. I kept tweaking these slides, sorry. But what I did was I called the doctor with that and told the doctor about what's going on, called a speech therapist, told her what's going on. And she's like, so he's good to go, right? We don't have to do anything different. I said, just talk to the speech therapist there. He's still aspirating, but I listened to his lungs and radiology. They were still perfectly clear, right? So this is what's interesting. Oh, he had a safety of a 2 on the patterns of aspiration and penetration, an efficiency of a 1, an overall score of a 2, which is moderate, right? So most people would not want to feed this person a regular diet. So now for the rest of the story, 1 month later, right? I look on my caseload and Robert's in our ICU and I thought, no, he can't be in the ICU. And I look and he's back in the ICU for what? Sepsis. from his urine catheter, awaiting a prostate surgery, right? They call me in. He recalled me. I walked in. The first thing he said is, "That's that Sicilian girl." He still had his swallow precautions. He handed me the swallow precaution. He brought it to that wife brought it to the hospital with her, and put it on his thing. He's alert. He's oriented. His pulmonary system was perfectly clear. He had his EMST. He had his EasyPep, and he could show me that he could do them independently on his own. And the ICU docs are like, "This guy's got a history of that much aspiration and we're letting him eat." And I said, "That's what they want." So we had him alternate solids and liquids to make sure that it clears his pharynx. Up in a chair, he would brush his teeth before meals, after meals. We had the respiratory therapist do a lot of pulmonary tasks. I followed him like twice. He went back home. Finally, the wife called and left me a message because I asked her if it's okay if I use him as a case example. And she said, "Absolutely." And she said, "He's doing good." He said every now and then he coughs, and I think that's great. And I just hand him his pulmonary stuff, and we're going to just keep him out of the hospital as much as we can. So he was doing really well. So there was a patient who, let me stop sharing, and Brooke, there's a patient who I thought was a great case study because he's nervous. I mean, not much makes me nervous, but I'm old. I'm an old bag, but, they make me nervous. A patient yesterday I saw was nervous just because he had his eyes in the back of his head, and I had the PCT check his blood sugars, and they were 40. And I'm like, well, this is why he's not responding. That makes me a little concerned. But for some reason, if you look at that whole picture, that guy looks like he's ripe for aspiration pneumonia, and he's going to die. And we should sign something that he's got to have nectar liquids and sign something saying we're not going to be responsible. When they had clear preferences that were against what most speech pathologists would be comfortable with. And the doctor just goes, "So he's okay, right?" And I said, "He's okay." I didn't say he's great, but I said he's okay. And this is what they want. And we're going to do what they want. They're absolutely okay with the fact that he may aspirate and die. And he keeps saying to me, "I don't think that's how I'm going to go." He goes, "I think it's my person." Well, that's not an area that I'm an expert in. So I am not. That's your shtick, not mine. I'm not going to deal with that. But he was really funny. But the wife was really nice. He even got on the phone and talked to me. So he comes in with UTI. So how I would probably 75% of the audience, if there's 10 people here or 100 people, would be really uncomfortable with what we did. But remember, predictors of aspiration pneumonia, right? I mean, yeah, he had a UTI, but he wasn't immunocompromised. He was able to brush his own teeth. He was able to independently do his flutter valve. Slow, but he could do it. And he was alert and oriented enough to know what he wanted and what he didn't. We didn't do this on someone who was, completely out of it and was at risk. So the PT and OT totally got him into brushing his own teeth, feeding himself. And we were just a team. It worked really well here and in the skilled nursing facility. And the speech therapist guided that team there as well. She is super strong and just said, "We're going to do what the hospital said. We're going to do what the family said. This is really risky for us. We think it's really risky, but this is what the patient wanted." So I know that was a lot and it was fast. I'm sorry, but I just thought that was such a cool, when a patient comes like that to us, we're like, this is a cool thing for people to see and think, we did it. We gave that patient what they wanted. And when his wife was sneaking coffee every day, I'm thinking, well, then why are we thickening stuff? Seriously. And she just said, "I'm not supposed to tell you this, but that speech therapist was really strict, so she didn't have him go back to that one." And she's like, she demanded that he have thicken and nothing, and I would sneak his coffee in. And I said, "Well, if you snuck his coffee in, how did he do? Tell me how he did. I'm not scared of that. Tell me how he did." I'd rather have people tell me the truth than lie and sneak things, especially like water. I mean, unless your mouth is nasty, do you ever let people not have water? So anyway, there's a bunch of questions.
Amazing. Quick side note, if anyone needs to log off, since we are right at 9 o'clock Eastern, that is totally fine. Just make sure you fill out the survey, which is in the chat. And I forgot to mention this. We'll need that filled out by next Thursday to submit for ASHA CEUs. On Joe's note about assessing risk versus benefit, we did a session earlier this year with Dr. Phyllis Palmer and Aaron Padilla on the Bullis framework. So be sure and check that out if you haven't already. We do
And
have a lot of
that helps
questions.
you, right? That bolus framework, I know Phyllis really well. That bolus framework, if you've got it in that head, then you don't get so nervous about stuff.
Definitely.
So that,
Okay,
go ahead.
we have several questions. Let me look through quickly. I'm going to start with this one because this was asked earlier this evening. An attendee said, you mentioned not using food items brought into the radiology suite for an MBS. Wondering if you could elaborate, and just curious if this could be utilized for patients such as in head and neck cancer, where their diet can consist of specific items in addition to the Veribar products and protocol.
Just CMS is really, I mean, first of all, radiologists think we're nuts when we bring stuff in. I think a head and neck cancer patient is different as a pediatric. Sometimes you got to doctor things up for pediatric. But for the most part, the Veribar products, unfortunately, Veribar doesn't have solid food. So you got to take a Lorna Doone cookie or a cookie and you mash it up and you put it in that and say, I'm going to coat this, and then you have to chew it. But I don't usually use anything but liquid nectar. We never use honey because of protocol 201, and I don't do a lot of peds anymore. I stopped doing that. And then a solid food Lorna Doone cookie and a pill. That's what we use. And I don't mix things up. Some people like to mix like fruit cups with stuff to look at a mixed consistency. I like to look at the pill with liquid. And for me, I water the barium down, not because it's going to change the viscosity as much as it's going to change the color. So I can see the pill with the barium a little bit better and see what a mixed consistency looks like taking a pill. Some people will give a pill. I did standardization of MBSS through our whole corporation, and they gave a pill with water. And I thought, well, how do you know if they've aspirated with the water in the pill? So you gotta give it a little bit of barium. But I don't bring CMS. If you do that, don't document that you mixed it with stuff, because CMS sees that, it'll be a huge red flag. They don't want us mixing stuff in radiology anymore. I don't have a strong precedent. Your radiologist will have a much bigger, stronger bias about that, but I just use Veribar products. Go ahead.
Question about the case study. What would your recommendations have been based on what you saw if the patient had not communicated the preferences that he did?
That's a really good question. I would have done the same thing.
Wonderful.
Just because he never had any pulmonary problems. So he was home and he came in with a UTI and didn't, I mean, if he came in with congestion and bilateral opacities and all that kind of stuff, had been different. But he came in with a UTI and some encephalopathy from the UTI. His lungs were clear, his CBC was clear. He's got really good immune system. I looked at his neutrophils and all that. So I do labs. I look at labs and look at all of his neutrophils. Can this guy fight an infection or not? I'm very, because I'm seasoned and I'm old and I've seen a lot, unless you vomit and aspirate, I rarely, I think I put people on nectar liquids or slightly thick liquids probably 5 times a year. I'm in acute care. We do IV fluids and water. I rarely put people, I try as best as possible to get that person on the most normal type of consistencies as I can. But that's, you go through your head, like the bolus framework, you go through your head about what are the risks for this, what are the risks for that. And I'm like, he aspirates, but he's mobile, but he's slow, but he's religious about his pulmonary tasks. And that was the one thing that he didn't do in the care center. And he was on nectar liquids. And the wife was sneaking fluids in him. So good question.
And there's a lot of questions in the chat about the bolus framework. We do have the replay up on our website. So just check out the Timms University site. The replay is up there. And Dr. Palmer and Aaron have a wonderful infograph that you can download. We have that hanging up in our acute care office at the hospital I work at, which is a really nice just visual reminder of the bolus framework.
There's a really good article that's written too that Phyllis wrote, but his name's Aaron, I think. That's great. And I can send that PDF to you too. I mean, our colleagues use that all the time and show a doctor, look at, this is what we're doing. Because they always say, well, just show me the evidence and we'll do what you want to do. So
yeah, I have that reference as a smart phrase in Epic for the one of their recent articles. There's a couple of questions about where to learn more about some of the topics you mentioned. So one of them was, do you have any references or recommendations for learning about lab values and what we as SLP should be looking at or what they tell us?
I learned about lab values actually from a dietitian's. So when I onboard people, I will try and take most of the caseload from that person and I have them follow a dietitian around for 2 or 3 hours. And a dietitian will let you know whether someone is malnourished, not malnourished, hydrated, not hydrated. And that's, there's a lab value one, and I can't remember where it is. It'll come to me when I'm having a cocktail tonight and I'll email me, whoever has that. Cause I know is it John Ashford that has one? There's somebody that has lab values. It was a long time ago, but I learned lab values a long time ago and I've lectured about it. It just makes sense. Like if you have someone that's had a head bleed, they go in and they put drains in, they're going to want their sodium level higher than normal. Normal is 135 to 145 and sodium is extracellular, right? So that keeps the edema down in the head. So I'll tell patients, well, they want your sodium, that's a number from 145 to 155. So you're going to be thirsty because your body naturally is going to say, drink. My sodium's too high. And so but they want that sodium high to keep the edema down in the brain. And so I tell patients you're going to have like popsicles, Gatorade. We can't give you water, and this is why we can't give you water, but the cellular level is so perfect. It's like such a blessing from God. It's so perfect that you can tell when someone's going to be able to fight something by looking at lab values. And if you want, just email me and I'll find it. It's in the back of my head, but right now I can't.
Dr. Palmer's here. Hey, Dr. Palmer. She said Mills and Ashford did an article in the SIG in 2008 that provided a nice overview of lab values. Thanks, Dr. Palmer.
Thank you,
So,
Dr. Palmer. Thank you, Phyllis. We love your bolus framework. She's fantastic. She really is. That's such a good way to make critical decisions in your head.
definitely. Well, I know we're a little bit over time. We didn't quite get to all the questions. There was a lot of questions asking for resources. So just to recap what we said earlier, the references that Jo mentioned in a PDF from Dr. Grand will be on our website within 48 hours. A replay of this session will be on our website as well within 48 hours. I did put the survey in the chat and the Q&A a couple of times, but if you weren't able to get it because you were on a cell phone, just send me an email at tims-univ@tims.com and I can send you the direct link. Same thing if you're wanting a certificate of completion, just send me an email there. Sometimes we get requests in the surveys, but we typically have about 300 people, which is what we had tonight. So I sometimes miss those requests. So just send me an email and I'll make sure to send you one. And with that, Jo, there's a lot of positive feedback. So thanks everyone for the positive feedback.
All right,
Jo is
that really fast. I'm sorry I ripped that fast, but I just want you to know when you get older, things slow down, but our bodies just recover. Keep strong, keep moving, keep your mouth clean, right? Dr. Palmer, thanks so much for being here. That's like, I'm glad I didn't know she was there. I would have been nervous. I'm nervous already, but I'm always nervous when I know when someone's in the audience. So thanks for
thank you so much, Jo. And thanks everybody.
Questions. I'll send that stuff to you. I'll send that stuff to you, Brooke.
Okay, sounds good. Thanks everyone. Have a good night.
Thank you.